Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
So this is one of my regular talks about PrEP, and there hasn't been that much going on. So I have decided that I'm going to talk a little bit about a recent manuscript that came out because I think it was an interesting manuscript, although it wasn't particularly groundbreaking. But I wanted to use it as a leaping point, taking off point, for talking about some other things related to guidelines and the FDA in terms of standard of care and what is required for us as physicians and other prescribers in keeping to the standard of care. So you may wonder as we go through this initial manuscript why I'm talking about it, but just have patience with me and it'll be clear. So there was a recent paper came out in AIDS patient care and STDs looking at how well providers in the U.S. adhered to the PrEP guidelines. As you know, we've had PrEP guidelines since the PrEP first approval of FTC TDF as PrEP, and then there have been revisions, and we have two sets of guidelines. But these authors wanted to look at how well could we assess whether or not people are adhering to those guidelines, and number two, how well providers are doing. So these guidelines have existed. We haven't had this information. And there are data for HIV care related to adherence to guidelines and outcomes for patients in terms of morbidity, mortality, and success with antiretroviral therapy. But those data don't currently exist for HIV pre-exposure prophylaxis. We don't know whether infectious disease doctors provide better care or worse care, I'll put those in quotes, better or worse care than primary care providers, or whether or not that's impacted by the number of patients as it is with folks who are HIV positive. And the idea of doing this analysis was that if you could identify providers who are doing well or less well in keeping to the guidelines and taking care of the patients, that you might develop interventions in order to improve the care. And then, as perhaps important for this talk, I just wanted to explore issues related to guideline adherence, the Food and Drug Administration, and what we consider the standard of care. And the reason for that is we've had several conversations over the last, 6 months or maybe a year and a half, I can't remember anything based on time these days, about, for example, the recommendation in the most recent guidelines, it must be a year and a half, to do HIV nucleic acid testing with follow-up care for oral PrEP, and why you may or may not adhere to those guideline recommendations. So I wanted to explore those questions. So focusing first on this paper, it was a assessment of pharmacy-based records. So looking at folks with commercial insurance and looking at their claims, using claims for inpatient admissions, outpatient services, and medications. They were looking at patients who started PrEP from between 2011, so even before FDA approval, and 2019. Fairly old as we think about PrEP and the uptake that we've seen in PrEP over the last few years. Because interestingly, pharmacy claims don't associate with the provider has written the prescription. These authors had to associate the PrEP prescriptions with someone who made a claim for a test related to PrEP care, put that in quotes again, that was closest to the first PrEP prescription. So they associated that patient and their PrEP with the first provider, preferably either a primary care provider or an infectious disease provider, before the PrEP prescription got filled, and then associated all of their PrEP care with that one before. So one limitation there. They assigned all subsequent tests to the one provider before, and then looked at the care provided, looking at providers who had a single patient who was receiving a PrEP medication versus more than one, because the vast majority, interestingly, of providers in the United States who are prescribing PrEP, the majority of them actually only have a single PrEP patient. They looked at tests for PrEP care using broad CPT codes. One of the challenges that we could talk about in doing this work is that there is no ICD-10 code for PrEP for pre-exposure prophylaxis, or even PEP. I think most of us use exposure for HIV for these. So there's a large variety of PrEP codes that are used for PrEP, and they defined adherence really rigidly initially as you needed to have an HIV test within 7 days of PrEP start. This is what was in the guidelines. I don't remember if it was the original guidelines. It was certainly in the second revision of the HHS CDC guidelines. And then you needed to have follow-up HIV testing and creatinine and STI testing within 14 days of that 90-day window that is recommended in the guidelines. They consider providers to be, lots of air quotes today, higher quality if you had claims for at least 60% of the tests that were recommended. And then they did lots of sensitivity analyses around the number of days, the number of tests, which groups of tests to do in order to try and identify what factors might be associated with being a higher quality provider. Just a link to the guidelines that I think that they were referring to. This is the updated one. Again, there have been a series of them. So of the patients who started between 2011 and 2019, there were not quite 30,000 folks who started on PrEP. And of those, they were able to link these patients to a provider less than half the time. You can talk about all the reasons why that might be true or not. Again, these are commercial patients who are being seen, who had a prescription written and who had claims for other HIV care. So if someone had a prescription, I put myself in these a lot of times. So I might have in the early days written a prescription for a patient, but they were getting all of their other care through either a research study or through public health supported mechanisms. So there may never have been a claim for the HIV care. And so that person might not have been able to be linked to me, even though I clearly wrote the prescription. As we talked about a second ago, nearly 3/4 of providers were linked to only a single patient. And then surprisingly or not surprisingly, we can talk about this, only 6% of the providers met the definition of higher quality, according to this manuscript. About a third had not a single claim within the 7 days of prescription being filled or 14 days within that window period. 40% had no claims at all for HIV testing specifically. But I think the thing I thought that was really interesting about this analysis was that they identified that higher quality providers were more likely to be primary care providers and non-infectious disease providers, although this wasn't statistically significant. And higher quality providers were more likely to have only a single PrEP patient associated with them compared to providers who had 2 or more. This was statistically significant. Again, both of these are opposite what has been found in the past related to HIV care. Lots of limitations about this analysis and analyses like this, which we can talk about if folks are interested. But one of their conclusions was in thinking about who is following guidelines versus not, is it possible that if you only have your primary care provider with only a single patient, that you're more likely to follow the guidelines because your patient comes to you, you go, I don't know what PrEP is. You go and look at the guidelines and go, I need to do all these things. Whereas if you're a more experienced provider, that you have a lot more flexibility, maybe you don't stick to the windows, maybe you're a little bit more lax and not following the guidelines exactly. Or is it possible that experienced providers are more comfortable doing something like same-day PrEP, where you might write a prescription, but then you never follow up with labs. And as a provider, you have seen so many patients on PrEP that you're not really as concerned. Or is there something about more experienced providers seeing more folks who are at risk and more likely to, maybe like myself, use insurance for the medication, but have the HIV, STI, and other testing being covered by another means? And then my editorial comment is that this sort of assessment is really challenging. Even identifying who are PrEP patients in our population is really hard because, again, there's no code. But as I mentioned, I just thought this was really interesting, and we've had some really interesting conversations about guidelines. And I wanted to do a little bit of a dive into what clinical practice guidelines, how rigid do we have to be in following them? And clinical practice guidelines have been around for 30, 40 years. The number has been increasing, as you might expect. The whole point of this is to improve patient outcomes in order to standardize the practice of medicine. And the there are criteria for what the guidelines should be and how you should think about whether a guideline is something that we should be following as providers. This Institute of Medicine report was first in 1990 and updated about 20 years later. And they say that your practice guideline, their CPG, should be based on a systemic review of evidence, be developed by knowledgeable multidisciplinary panel of experts and representatives from the key affected groups, should consider important patient subgroups and preferences, probably really importantly, have an explicit and transparent process to minimize bias and conflict of interest, provide ratings both on the quality of the evidence and the strength of the recommendations, and then be revised as appropriate. Because one of the things that they found is that it's about 1 in 5, I believe, was the estimate. 1 in 3 guidelines will be out of date within 5 years. So they really need to be updated regularly. So I think there are 2 issues related to all this. The first is in the development of the practice guideline. One is there quality evidence that is used for this review? How does the guideline manage the bias and conflict of interest? And then this issue of obsolescence. And then there's a huge body of work around implementation of guidelines. I remember Bernie Branson, when we talked about the HIV testing guidelines, said that it's about 10 years before you can really see uptake of guidance. So there are challenges in dissemination. There are problems when you have, like we do, 2 separate sets of guidelines, some of which may conflict a little bit. There's the overarching issue of, do physicians want to do what we want and don't want to pay attention to guidelines? They rarely consider the rare individual conditions, people who may have multiple comorbid conditions on multiple medications, and they don't often allow for the individual variation or preference. So they may not be as patient-centered as some people may like them to be. One of the things, so I'm trying to give you examples from the infectious disease world about these guidelines. So one of the issues is, do you have to follow guidelines if the evidence supporting them is weak? And this is just an example. Again, you can see it's from 2011, so fairly old when we think about how much medicine has changed. But this was an evaluation of all of the IDSA recommended guidelines. And as of 10 years ago, there were 41 guidelines from the Infectious Disease Society of America. Now, of those, there were 4,000 plus recommendations, only a small number of which were based on a randomized clinical trial. And then among all of the Class A recommendations, which there is good evidence for, that only a quarter were based on randomized clinical trials. So if you looking at the figure, it's in black that recommendations are the randomized clinical trials, and the vast amount of gray is based on expert opinion alone. So a lot of the guidelines, and I think Shrisha was on, or others who can talk about development of guidelines, that a lot of it is expert opinion and that we don't have randomized clinical trial data for everything that we are recommending as part of guidelines. And thinking about obsolescence, this is the one that comes to mind. This is the recommendations for non-occupational post-exposure prophylaxis, which we all know is very old and due for updating, and hopefully we'll see it this year. But the medications that we've had in 2016 when this recommendation came out are outdated. And I think many of us are doing something different than what's in the recommendation just because we have, there are better medicines. So do you have to follow them? Well, one of the things you always think about is, if you're following the recommendations, am I less likely to be sued? And I think it's interesting. I was looking at a lot of the medical legal information that's out there. So the development of clinical practice guidelines is to improve care, but not define the standard of care. And interestingly, there are different state regulations about the inclusion or the exclusion of practice guidelines in case litigation. And so the thought is, if you can use this, so lots of times the defendant wants to exclude the practice guidelines if they weren't following the guidelines. Because again, if it's considered standard of care, then not following the guidelines might be considered below the standard of care. On the other hand, they might use it as a defense, saying, I was following the clinical practice guidelines. And so the case law is really very variable, and it's on a case-by-case basis, whether or not they can use it. So you can't rely on following guidelines or not following the guidelines as part of litigation. I think, although it is more likely that a lawyer is going to pick up a case if someone was not following what is considered standard practice guidelines. And then thinking of the FDA approvals, again, I've looked at this related to nucleic acid testing because there are specifics in the FDA package inserts for both FTC TDF, saying that you should test at least quarterly for HIV if you are prescribing FTC TDF as PrEP. Similarly, there is in the package insert for injectable cabotegravir the requirement to test for acute HIV infection. So do you have to follow what's in the package insert? And I thought it was interesting. There is a quote directly from the FDA website. The FDA does not regulate the practice of medicine. Their goal is to ensure that the medications available for marketing and sale are safe and effective. But as you all know, off-label use of FDA-approved medicines is perfectly legal and eventually does represent the standard of care. And just like the inclusion of practice guidelines in case law, states differ whether the package insert for medications is actually the standard of care. And the only thing the FDA does actually speak to is it will prohibit manufacturers from their own promotion and supporting of off-label use. So they can only provide advertising and promote the use of their medications for which there is an FDA approval, and they cannot support in any way things for which they're not FDA approved. So I didn't actually shed a whole lot more light myself on sort of whether or not you have to do all these things. I think the thing that I saw over and over is that people are trying to identify what the standard of care is, but the standard of care doesn't represent the optimal level of care, and we should all be striving for the optimal level of care specific for our patients.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.